Hi, so good morning, good afternoon, good evening, depending on where you're joining. It's a pleasure to welcome you all to this webinar to discuss global health and the impact of COVID-19 on global health service delivery. My name is Nina Sun, and I am Deputy Director of Global Health at Drexel's Dornsife School of Public Health, and I'm also an Assistant Clinical Professor in Community Health and Prevention. I am very happy to be joined today by three esteemed speakers and panelists. So the first speaker we have with us today is Marian Wentworth, who is the President and Chief Executive Officer of Management Sciences for Health. So for those of you who aren't aware, MSH is a mission-driven global health nonprofit that has been operating globally for over 50 years. It has several areas of expertise, including health system strengthening, as well as packages of care for HIV and tuberculosis, as well as women's, children's, and adolescents' health. Before she joined MSH, Marian managed global strategy for global marketing, manufacturing, and research at Merck & Company, including its vaccine portfolio. The second panelist that we have with us today is Dr. George Kimathi, who's the director of the Amref Institute for Capacity Development. The Institute, which is part of Amref Health Africa, aims to resolve and address challenges in human resources for health on the African continent. In his role as the director, George provides overall leadership to Amref's Human Resources for Health agenda. He also sees the diverse education and training programs that Amref has in over 20 countries. Prior to this position, George was the Deputy Country Director for Amref Kenya's program. And before that, he has held leadership roles in various international NGOs, as well as the government of Kenya. And also, very importantly, we have Margaret Schroeder, who's the Senior Vice President of the International Programs at World Vision USA. World Vision is a faith-based humanitarian organization that works in countries in Latin America, Africa, the Middle East, Asia, as well as in the United States. World Vision works on a variety of issues, including clean water, economic empowerment, disability inclusion, and of course, health. Margaret oversees World Vision USA's international programs, including those related to water and sanitation, children's health, and emergency responses. She's also been a champion of building women's leadership in the organization's programs. So with that, I'd like to give a warm welcome to all the speakers. We are incredibly thrilled to have you with us today to share your experiences, to share your challenges, to talk about how COVID-19 has really impacted your work and the work that you oversee in the various countries. So before we delve into the questions and start hearing from you, I wanted to, just say a couple words on the COVID response, which seems so overwhelming to sum up because it has been an integral part of our lives for the past year. So as of this morning, there have been over 158 million confirmed cases with 3.3 million deaths globally. And we're at a turning point right now in the pandemic where in some countries, there's so much hope with emergency use of vaccines, but in other places, it just seems still incredibly tragic and health systems are overwhelmed. And some countries don't have access to those vaccines just quite yet. And with that framing, I wanted to turn to you and hear from all of your experiences in the past year, the experiences of your teams, of your colleagues, and ask, how has COVID-19 really affected and impacted your programs, and how have you adapted? So let's start with Marian. It would be great to hear about MSH's work in the past year.
Great, thank you, Nina. And it is definitely an honor to be here with you and with Margaret and with George to have a really important conversation. And I hope there are some generous questions because there's so much to say. And we've just got to tailor it a little bit to who's listening and where we're interested, because we can't cover it all in an hour. I wanted to start actually with, an aspect. There are outbreaks every year in so many places. There are more than 200 outbreaks a year, and MSH operates right now in about 35, 36 countries. And so we are frequently in the middle of outbreaks, and there are things that we do, and there's a little bit of a rule book that we follow. But a pandemic is different, because a pandemic covers everybody all at once. And one of the things that I want to highlight that maybe you don't hear so much about is, for those of us in development and state departments and things like that, one of the things we kind of did up front is a lot of expats left countries. And that really does depend on what organization you have and the degree to which you try and hire locally versus have expats. But we also did things like, try and hang on to, as countries, we got very nationalistic. Even before we went to vaccine nationalism, we got kind of nationalistic, and we started kind of sending a message that you're on your own a little bit. And I think that was exacerbated by the fact that there were sort of nationalism trends going on in a number of countries anyway. But I think it's really important now that we're seeing, new highs of disease in more countries, that, over the past year, there's been a very mixed message in terms of whether we're here to support, or whether it's just every person for him or herself, for themselves. So anyway, you did ask about MSH. We really tried. We did have to protect the safety of our employees, and sometimes that actually meant that some expats went to their home countries. And that was actually incredibly important for us, in part because the usual system of emergency transport and so forth was actually falling apart as well. But what I actually want to turn to is, when you're in 36 countries, you've got really different and diverse situations in terms of need and complications. And so it was extraordinarily important to us not only to put in place some systematic thinking about when do you ask individuals to work from home, when do you stop certain activities, how much leverage do you give to talk to and try and convince donors or ministers or whomever that, in person isn't necessarily the best way to accomplish this particular problem. But the situations were so different that we put together some global guidelines. We put together a global COVID-19 task force, a lot of things like that. But we also put together routine. We probably overdid this for a while, but I think overdoing is the right thing. Communications, especially country leaders to country leaders, and at one level down in terms of technical, to share information, to share ideas, and to develop strategies, because there, as I said, there's a certain amount that you can figure out top down, but there's a certain amount that really has to come from the collaboration of folks who are living the circumstances. I can tell you, being a US-based organization, that a lot of the things that we were looking at in terms of US data sets and so forth just weren't going to apply to Madagascar. It didn't make sense in Malawi. And there were also things that we would never have thought of doing before that turned out to be far more possible. We did actually do far more education virtually in countries that you would have thought maybe you couldn't do that yet. But it's amazing what we learned along the process. But I would say I'd like to leave you with a couple of things. One, it was really important for us to make sure our staff was safe first. And that was not easy, and that was not once and done in the beginning when information was coming in dribs and drabs, and sometimes contradictory information from one week to the next. It really required a surfeit of communication. And two, we really wanted to pay attention to both what we needed to do to respond to the COVID-19 crisis specifically, but how you could preserve essential medical services. Because we are in these different countries in order to save and protect lives. And if all you do is trade off one source of potential morbidity and mortality for another, you're not necessarily gaining ground. And coupled with that, it was really important for us where we could to make sure that our COVID response was strengthening our essential medical services response. I'll stop there so we can have a chance to hear from our other lovely colleagues.
Thanks, Marian. There's so much to unpack there, but I want to give space to George and Margaret as well, who I'm sure have very fascinating experiences. So I'll pass the floor now to George. I know Amref's Capacity Strengthening Institute also has done some online work, and so I'm curious to hear how you've all adjusted.
Yeah, thank you. Thank you so much, Nina, and thank you for having me on the panel for this discussion. Listening to Miriam, I think our experiences are more or less the same. But perhaps the only difference is that Amref, just for the sake of the participants here, is an international health development NGO based in Nairobi, started here 63 years ago, and we work in 10 countries across Africa. So our experience will be different slightly because we are based in the south, while say what Miriam has shared is for a global health NGO that is based in the north. So what we saw first is largely what Miriam has shared. I think first of all, it was this thing has come, and as I shared earlier, we don't necessarily as Amref have a huge program that looks at emergency response. So when it came, it was a boom for us. So we had to figure out how best to navigate. First of all, in terms of programs, it meant that lots of disruption of programs, absolutely. And we've done us cutting across, which was not easy to negotiate with. So programs meant that we couldn't conduct activities. The COVID-19 guidelines came, the cessation of movement, lockdowns in some of the countries where we work, meant also that, of course, we could not do meetings with the communities, with the government officials, with the CSOs that we work with, which became really tough for us. We couldn't do support supervision that we normally do a lot. We couldn't do trainings, in-person trainings that we are used to. So we had to figure out how best to work that. But again, staffing, as Mariam indicated, wasn't easy for our staff. Luckily, of course, COVID hit Africa a little bit later, and the numbers have not been as high. Of course, although it's contestable, because we know we also don't have as much testing capacity. But we had staff who got infected, and therefore we had to find a way to support them psychologically. COVID has huge stigma. There's a lot of stigmatization of COVID even to this day in Africa. So when you get a staff who is infected, then you have to find a way to provide the psychological support that's necessary. You have to find a way to cover for them during hospitalization and as they get well. And then lots of stuff. So we had to kind of adopt a learning by execution approach, whereby as we are starting, programs have been disrupted. We have to find a way of continuing the same programs. You don't have a template where to lean on to or to refer to. You just have to find a way to keep working. We have field offices which are not as strong, and this is an operational challenge that we also encountered. And we realized that because we provide them support from Nairobi, it was very tricky for us to do that. We have colleagues who are based in Guinea, who are based in Lilongwe, Malawi, not very strong team, not very big portfolio, and therefore that means their systems are not as strong as what we will find in country offices. And therefore that's presented a huge exposure for us as an organization, providing virtual support to those kind of teams. Huge challenge. But again, luckily, we had developed some virtual tools for some years. One tool that is called Jibu, which is an online learning platform, which we use to train to train healthcare workers. We've used it across a couple of countries. And so we were able to leverage on that and use it for training, for meetings and such, both for our teams, but also for the other stakeholders that we work with, CSOs, ministries of health and such. And then LEAP, we had also developed a tool that was largely being used in Kenya for a couple of years. But because of COVID, we realized, as someone said the other day in another meeting, it seems like where there's a will, there's actually a way. So we find a way of penetrating Ethiopia, which was not a very easy market area to have conversations with the government. We find a way to roll it out down south in Malawi and Zambia, and also even in Francophone countries, which helped us then to move on with activities. But again, for staff, as Marian said, we had to find a way to support them to work from home remotely. But then we realized, and we have cases, we realized that not all of us who actually work from office can really work from home. It can be a cut and paste for me to be able to work from home because I need internet. And most of Africa is not necessarily well covered with fiber optic. So it became very tricky. Most of the places where our staff work, like in rural areas, rural districts in say Malawi, in South Sudan, you cannot get internet. You cannot even get phone connectivity. So then what does working from home mean? Literally, even when we want to support our staff. So it became very complicated to find a way to make that work. Working from home again means that you have to have the luxury of an extra room where you can sit and work from. And that's complicated because then some of our team members have a 2-bedroom house or even 1-bedroom house, and you have young children. Again, we have a huge team that is quite young, so they have young children, the 2-year-olds, 3-year-olds. What do you exactly do in the house? How do you exactly work in the house if you have a 2-year-old in the house? It became very complicated. But then again, even power. These are practical challenges of working from home that we realize, and therefore we had to come in to support with some bundles. Some cases, even basic things as furniture, just to support our teams to work, and then of course providing them with psychosocial support that is required, because mental health became a big challenge for all of us, of course, during COVID, and therefore for staff we ensured that was happening. And basically, of course, the other support to ensure they are safe, provide them with the basic PPEs, the basics like sanitizers and such. But I think that what I learned to do in that time, as we are finding a way to navigate and to make it work, was that working remotely can actually be conceptual until you get to practicalities, and then you realize it can actually be very complicated, and you just have to find a way as an organization to facilitate that to happen. And of course, we integrated most of the COVID work within the programs that were existing, so we were able to layer work there. We were able to also attract quite some resources to do COVID response work. But now, transitioning to COVID vaccine, we are definitely seeing very little investment to support vaccine rollout, which is again presenting challenges for us quite a lot. Nina, I want to pause there for now. Otherwise, as Miriam said, we can chat for our day on how we've experienced COVID in our different organizations. Thank you. Over to you.
Thanks, George. Just to also remind participants that you can send any questions that you have for Marian, George, or Margaret in the chat, and we will get to those once it becomes the question and answer time. I'm sure you have many questions already. And of course, I would like to turn to Margaret to share World Vision USA's experience as well in the past year.
Yeah, great. Thanks so much, Nina, and so wonderful to be with you and all the people who have called in, and George and Marian on the panel. I'm just grateful for the opportunity. So, just very similar to what Marian and George have been talking about, COVID came and had devastating effects on the communities where World Vision works. And, we've all heard about the decades of development gains that are slipping away. As rising poverty, lost jobs, and that desperate situation in many of the places where World Vision works, it resulted in families really making some impossible decisions to send children and young people to work or beg or to get married in the case of child marriage and migrate. World Vision is a child-focused organization, and so we were particularly concerned about the impact of the pandemic on the well-being of children. And indirect aftershocks of COVID-19 are really being felt by billions of people around the world. And at its peak, COVID-19, as many of you may have heard, COVID-19 forced schools to close nationwide in 194 countries, affecting 1.6 billion learners, or over 90% of school-going population. It's just crazy, the impact on kids when you think about that statistic alone. And so in most of the countries in many of the countries where World Vision worked, the pandemic caused a public health emergency and a socioeconomic crisis. So this complex situation in many of our countries, it provided an opportunity for, it necessitated really the opportunity to collaborate across different functions, development, peace building, and humanitarian functions, because all these issues that we're dealing with out in the field are interconnected. So for World Vision, within 3 weeks of the UN World Health Organization's declaration, we had what we called a global emergency, COVID-19 emergency response plan to target over 70 countries. So we basically mobilized in both more stable contexts and fragile contexts to respond to the pandemic. But, and so I just want to give a shout out to our staff. Over 90% of our staff around the world are local staff. And, they were able to pivot. We've heard this word pivot used so much over the past year, but the way that staff in the field were able to pivot was exceptional. And so what we did with our programs in the field is staff rapidly adapted their programming, our footprint, in response to shifting patterns of vulnerability and lockdown restrictions in many countries. But it took that partnership with community health workers, faith leaders, and other local volunteer networks to engage rapidly and collect assessment data to monitor children's well-being. Even during the lockdowns, we were able to do that. And really kind of astonishingly, this is another statistic for you, our recent World Vision survey found that 98% of community health workers remained mobile and actively serving their communities during the pandemic. That is just fantastic. So people were on the ground, they were committed, they were responding. And data collection became increasingly virtual during the pandemic. World Vision began to use technology maybe that it hadn't used as much, text messaging, integrated voice response, and phone calls as key tools to understand the shifting context and its impact on communities. And then that data could be used to make informed and evidence-based decisions to ensure that we reach the most vulnerable populations, and designed response interventions that were relevant. So a couple things about how the lockdown specifically impeded regular program delivery. And so it was really up to the field teams primarily to determine which activities were critical and which needed to be adjusted in order to deliver appropriate responses. And so a few things that we did out in the field: we continued essential work in refugee and internally displaced persons camps and settlements, including the provision of water and food. So some basic necessities, basic relief operations were not halted. Again, as I said, sharing key health messages through radio, TV, text message, and social media. And I mentioned before this expanded network of faith leaders of all faith groups to be able to reach people in their communities. And and conducting household level child nutritional screening sessions. So there was a lot of work for emergency and relief activities that continued. And then the other thing that I just want to highlight, in addition to what was been said already, we saw a significant increase in cash and voucher programming in 2020. So it almost doubled. In 2019, World Vision's cash and voucher programming portfolio was reached about 3.7 million people. In 2020, it reached about 6.3 million people. So you can see that even the donor funding was shifting as to what the focus was, and it changed our portfolio significantly in 2020. Aimed at reaching, responding to COVID around the world. So I'll talk a little bit in a minute about some of the lessons learned, but I will just say, overall, it was a huge change for World Vision, but a rapid pivot was needed. And, I was just pleased with how the teams in the field did respond, how the donors responded, and it's been a full collaborative effort. So, yeah. I'll just stop there.
Thank you, Margaret. Thanks for sharing those lessons that you learned so far. And yes, pivoting is certainly something that I think we've all had to do in the past year or so. So the three of you all made reference to needing to kind of pivot and iterate on the services that were delivered and integrated some COVID-19 specific services. I was wondering if you could tell us a bit more about, how that was done. So Margaret made reference to the fact that deference was given to the field offices to decide what was essential, what was not essential, but that's an extremely hard call to make in terms of how do you protect safety for your team members, for your staff, which I know was a core part of everything that you've all been doing in the past year. So I was wondering if you could elaborate a bit on that. So we'll start in the same order. So Marian? Over to you.
Well, I did want to talk a little bit about some of the, kind of the technical areas that were really in demand. That's a hard question in terms of safety as staff. I think we have heroic staff all over the globe that do things that would probably make my mother's hair curl, or go places that are, quite scary. So I think one of the really important things there is just empowering good judgment, and then resourcing as much as possible, but giving people safe space to say no. But in terms of the technical areas, we have both pharmaceutical systems expertise and broad healthcare expertise. And on the pharmaceutical systems, as you can imagine, there was a big draw right away. We run a global that includes global health security and other kinds of support. And so there was a big focus early on things like infection prevention and control programs, of which we were already doing some, but the scale of them increased substantially, and the number of countries in which we were doing them increased substantially. And then risk communication, of course, was also extremely important. And it might have been that we were doing risk communication already for malaria, for something else, but it shifted pretty quickly to COVID-19. How do I know I have COVID-19? What should I do in order to protect my family against COVID-19? Those kinds of things. And frequently the decision to put those communications programs in place came from the relationships that we already had, working with ministries, working with local district governments, working with community leaders. Those came about because there was quite clearly a need, and we were there with existing relationships and with WHO and our own resources that were credible and supportable. And it was hugely, hugely important to increase communication because there's a lot of misinformation running around, still is, but at the beginning it was particularly bad because it was so confusing. We also did surveillance, testing, tracing, contact tracing, and teaching others how to do those kinds of things. And as supply chain was more and more disrupted, there was a lot of supply chain services either doing the work or capacity building to help others do the work. Mostly what we do is capacity building, but in an emergency like this, it's all hands on deck. So it was definitely a combination of both of the above. And now that we're in a world where supply chains are still being terribly disrupted, I mean, I think we're going to be in that world for the next couple of years. I mean, they've never been stable, but COVID has caused, we understand how interconnected countries are when you have something like a pandemic. We're now pivoting to really support some of the vaccine related and treatment related supply chain work as well. We've also developed toolkits for local leaders to manage their own pivot and their own communications plan. And of course, we're also supporting a series of regulatory efforts. And I, in my own personal life, actually, I sit on a couple of different WHO committees. I also sit on government grant programs to fund vaccine development. I have some personal experience in vaccine development, quite a lot, actually. And so I spend a fair amount of time just personally doing that in off hours. So that's just a taste of some of the content. Some of it is repurposed specifically to address COVID-19. Some of it is strengthening programs that were already targeted to other kinds of essential services. For instance, our community health workers in a number of countries learned how to do contact tracing. Before that, they were doing family planning support and early childhood support and a number of really critical things. And they were still doing those things, but they were also going door to door and doing contact tracing. And just crazy things like delivering supplies because we have drivers, or helping some prisons emptied out early on in COVID because that was a high transmission kind of area. Our drivers drove prisoners home, and they did all kinds of different things. And of course, at personal risk, which is just extraordinary. So I'll stop there.
Thanks so much, Marian. It's really inspiring to hear about all of the work and the bravery that you and your staff have shown throughout this pandemic. And I'll turn now to George. Can you tell us a bit about Amref, how they might have pivoted, what COVID-19 related services you started integrating? Yeah, go on.
Yeah, absolutely. Thank you, Dina, and very nice listening to Miriam and Margaret. So we kind of designed our COVID-19 interventions for response around 3 key areas. And again, as you say, pivoting, leveraging on what was happening, but also using some of the assets, as I mentioned earlier, particularly digital learning resources that we had developed earlier. So we did a lot of work around, of course, preventing transmission across the different levels, communities and other facilities, a lot of work there. Lots of strengthening of health systems, of course, to reduce infection in facilities, but also to ensure continuity of health services. As I mentioned, we do work across all the other areas with huge programs in HIV, TB, malaria, the big 3. We do NTDs, do a lot of work in LMNCH. So we did a lot of work to ensure there's continuity of those services. But of course, now we are also doing quite some work in COVID rollout, vaccine rollout, and definitely preventing social harm. And listening to Margaret, the issues around schools and ensuring schools were safe, the issues that came with teen pregnancies, I guess some of us might have seen the numbers, which were not really good in Kenya, or really terrible. We had huge teen pregnancies across the region. Lots of GBV, gender-based violence again. So we did a lot of work to prevent social harm. But then specifically, where we did, I think, a lot of engagement was at community level, because prevention was key. And we deployed our whole society kind of approach, appreciating that you need community health workers, you need religious leaders, you need teachers. What we learned was that it was all about the trust capital that we built over the years. The fact that our officers and assistants on the ground could be trusted by communities to listen to them. Because as we all know, of course, initially COVID, people dismissed it, and lots of mates, of course, were there then, but even now. So because of our network of working with the communities of approximately 1.3, we are able to reach about 1.3 community health workers across the country offices where we work. So that helped us a lot. Did a lot of training, again, as I said, using the digital resource that we had created earlier, LEAP, L-E-A-P. So, and we converted materials to different languages so that then it was just not in English. It's also available in English, but we also converted it to Kiswahili for communities that would be more comfortable with that. In Ethiopia, of course, we translated that to Amharic. In Uganda, we use the local language there, Luganda, and in Southern Africa, Malawi specifically, we use the local language, the Chichewa. So which made it very easy for us to engage communities. Again, using the structures that are in those countries made it very easy. And as I said, we are also keen on, again, as I said, reducing social harm. We worked very closely with the private sector, particularly banks. In Kenya, we had a very good partnership and trained bankers through the Kenyan Bank Association, 47 banks, which worked quite well. So in this case, we were supporting workplaces to ensure that they were able to reopen after the restrictions had been scaled down a bit. But then we are also keen on the flow of goods and trade between countries. Again, appreciating that Amref works a lot within East Africa. We had a good partnership which enabled us to work with the immigration officials, ensuring that trucks are able to cross the border. Immigration officials are able to prevent infection, protect themselves, protect the drivers and other passengers who are crossing borders across the East African region, which worked quite well. I'm just picking a few that I think stood out for me. Lots of work again in WASH and IPC, because we realized WASH was a big thing, water, sanitation, and hygiene. We did lots of hand washing facilities, fumigation in their facilities and communities. But again, as I said, we leverage a lot on the resources that we already have. At Amref, we have a WHO accredited laboratory, which we've been using now for actual testing of COVID-19. So far, we've done close to 40,000 tests. So testing capacity in Africa, again, as I mentioned, is a huge challenge. So this lab came in handy to support testing for the government of Kenya largely, but also building capacity of government of Kenya testing labs across the country, which again is definitely a huge challenge. Luckily, also we had children's home somewhere in Nairobi. We converted part of that to production of PPEs, which worked quite well. And one of the other things that I think comes to mind, and which I think worked so very well, was use of our Amref flying doctors, which is a medical evacuation service that we do in normal times. And we use this to evacuate COVID-19 patients across the region. And then also for them to train civil aviation officials. Remember, with lockdowns and cessation of movement across countries, training aviation officials by colleagues who could speak the language. So our pilots and our engineers at the flying doctors could do that quite easily. But we've also used that service to deliver COVID-19 vaccines to remote areas, which has worked quite well. So, and maybe finally, just to say that moving forward, we've seen the need to build the capacity of leadership and management effective in public health emergency preparedness and response. So we partnered with WHO, Africa CDC, and Mark to develop a course that's going to focus on that. We also definitely sat in various platforms that helped us to support governments to put in place their plans, also respond, fundraise, and all that. We sit in the Africa CDC, so that give us a good opportunity to contribute there, and also to contribute at the AU task force for COVID-19. Most of our teams sat in the national task forces that were responding to, or currently even responding to COVID-19, and also even lower at the district and provincial levels, and that helped a lot. So in terms of providing technical support to government, but also picking and understanding the need of government and what the government wants to do, and translating that to resource mobilization, which enabled us to do quite some work in communities. Yeah, Nina, I want to pause there. Maybe just to say what I learned most from that was, one, trust, very important with the government, trust, very important with the communities, if you are to do effective response to a public health emergency. I think that came out quite handy. And of course, two, leveraging and using resources that you already have. I think that also worked quite well for us.
George, you took the words out of my mouth. I was going to say trust and working with communities also seems to be a big theme from all of the organizations. But I also wanted to turn now to Margaret to give you an opportunity to elaborate more on the work that World Vision has been doing.
Yeah, well, thanks so much. It's so interesting to hear about the responses from the different organizations. So when I talked earlier about allowing some flexibility and some decision making at the local level, that was though guided and driven by a high level strategy. So I think that is important. You want to put in place a high level strategy globally and then roll it out. But allow that flexibility and allow that, creativity and innovation and decision making at the local level. But our global response strategy really had 4 pillars. So the first pillar was to scale up prevention measures and to limit the spread, immediately. So we had, and I have numbers, but I won't go through the numbers, but we reached people through the prevention of behaviors and, things like hand washing supplies distributed, information, education, and communication materials printed and distributed. And one thing I don't want to leave this call without saying is, our work, World Vision has quite a large and extensive WASH program and also a partnership with Drexel on WASH. Capacity building, and I can't overemphasize how important that WASH work was over the last few years and to build the capacity of people in the field, because it was the WASH work, some of the hand washing methodologies, behavior change methodologies that we were able to tap into immediately, and when we pivoted to focusing on COVID. So that was great, and certainly will be a part of our future responses to COVID and other public health crises as well, but infectious disease issues around the world. So that was wonderful. But that was the first pillar. The second pillar was to work to strengthen health systems and the ability of health workers to respond. And certainly, as George said, really, this is all done in collaboration and in close coordination with governments and community leaders. It absolutely will not work if there's not ownership at the local level. So training of health, we did a lot of training of health workers, provision of disinfectant kits distributed to healthcare facilities. And then supporting people also to secure safe quarantine or isolation spaces. So very specific to COVID in that regard. So then the third pillar of our response plan was to support children affected by COVID-19 through education, child protection, food security, and livelihood. So that kind of those secondary impacts that are now really the longer term impacts of COVID and what the impact has been on communities. So again, reaching people with information, engaging faith leaders, community leaders, teachers provided with education and training support, children protected with child protection programming. I think George also mentioned about some issues with gender-based violence and protection issues. So that's an important part of our programming. I talked earlier about cash and voucher assistance. So that was another part of our response, and livelihoods training and a focus. And certainly those longer term initiatives will continue on following our initial COVID response. But yeah, some of the lessons that we've learned through all those programs, and then certainly advocating. So for example, as we do rollout of vaccines, equitable rollout of vaccines, the advocacy that's already ongoing about that process is going to be critical to our success. But, there were a lot of adaptations made through all those interventions. And certainly there were lessons to be learned. Just a few that I've mentioned, but just to reiterate, establishing global objectives and priorities. Do not lose the development gains that we've fought so hard and worked so hard to achieve. I think that's a key issue, is not losing momentum in the other areas that we're focused on. Trust, we talked about trust local offices to keep activities relevant, and trust local governments to engage and help plan. Mobilizing funding quickly in a global pandemic is critical. In any relief response, mobilizing funding and getting the work done at the field level is critical. And one thing that I'd just like to say is that during this last year, I think we can all agree that we've all stayed a little bit curious and alert, and just seek to identify new ways of working, understand and respond to new patterns of vulnerability, and just be flexible. So I would say, yeah, with that, I'll stop. But there is so much to continue to be said about and learned from the response to COVID, to this pandemic. Yeah, and I'm sure we'll be deliberating on those things for a long time.
Yes, very much so. Thanks so much, Margaret, for elucidating those 4 pillars that really guided your work. So we are almost at time, which is crazy because I'm just enthralled with listening to how you've all kind of responded, pivoted, hearing your stories. But I wanted to give some time for some questions that we've received. So given that we don't have too much time, I'll keep it short to 2 or 3 quick questions, and I'll throw it out and then we'll see. So one of the questions that we received is, given the fact that MSH, as well as other global health organizations, so I guess all of your organizations, had to repatriate some of its workforce due to COVID, is MSH and other global health organizations using this opportunity to reconsider its reliance on expat workforce, particularly given the rising calls to decolonize aid and global health? And, one of the questions that we had originally wanted to discuss, but have kind of run out of time to discuss, is this question about health inequity and how the pandemic has really exacerbated inequities between countries and within countries. So in that framework, the question was for MFH, but please feel free, Marian, George, Margaret, you all have great words of wisdom to share. So over to you.
Yeah, I'm happy to start if y'all don't mind. First of all, as something like 85% of our staff is actually hired locally or from neighboring countries. And we've been actually trying to increase that over a number of years, taking what are traditionally considered sort of headquarters functions and sourcing them in offices along with our projects, because that creates so many things. It pays off in so many different ways. It creates career opportunities. It helps us to understand the nature of the communities in which we work in ways other than just through the health lens, et cetera. So for instance, most of our procurement function is now based in Nigeria, even the global procurement function, and similarly with HR and with a number of other, and with some of the technical leaders that are often working on some project with some huge technical question, because that's what they love to do, but they have a global footprint in terms of their technical expertise. And there's just no reason that they have to come from the same office that I work in, particularly. But it's actually not enough just to have staff, because it's actually slightly easier to get to those numbers until you start putting an equity lens on it and start saying, well, who are the leaders of various projects? Who are the leaders in different countries? And so we've been working for the last 3 or 4 years to both increase the female representation of those leaders, because there was a real deficit when I came to the organization, and the local hire, having them come from their communities or from the region. And so we've made tremendous progress there. It takes work because we actually have to bring our donor organizations along, as well as, there's a lot of pieces to it. But as I said, when I wrote this down, when you think about sort of decolonizing development, who does the work is only the beginning. It's important, but it's nowhere near enough to make sure that we're bringing the minimum of ideas and baggage from somewhere else, and we're maximizing the participation, the expertise, the ownership, and the guidance of any of the work we do locally. And that means not just amongst health experts, even though we focus entirely on health. That means amongst political leaders, business leaders, faith leaders. There are many, many stakeholders, that person in the community that everyone goes to for wisdom, even though she has no, official title. I mean, those different kinds of stakeholders all matter extraordinarily to making sure that the work we're doing is sustainable and is not just, a cut and paste from some other part of the world that's obliterating, all that is beautiful and unique and precious about a particular geography. That is not easy. And I've really been looking forward to, more and more dialogue around how to do that better, because I think that's a journey, not a destination, and we have a long way to go.
Absolutely. Thank you for those words, Marian. George, I saw you unmuted, so do you want to jump in here and add?
No, yeah, I know we have no time, but I wanted to say I totally agree with Mariam. We are also struggling the same. Totally agree with you, Mariam. It's a journey, not a destination. We are toying around at Amref with the idea of actually having rethinking through our governance structures, because it has to start with the communities. We have to ask ourselves, what do we do to build the capacity of communities to demand for information, to push for accountability? How do we empower them? How do we give them the capacity to synthesize information from governments and hold governments accountable? So it has to begin there. But also for organizations is again going to the mantra of nothing for us without us. Nothing for us without us. So if we are working for communities, can we have structures, governance structures that allow communities actually to sit in our boats? At country level, can we have governance structures that allow community that have a process of ensuring communities, say through CSO, whatever it is, sit in the international board of Amref? That's actually the conversation we're having currently. Because then that way, if you are responding to community needs, then they are also seated in critical decision-making organs of the organization. That's all I wanted to say, Nina. Thank you.
Thank you. So great. I don't know if Margaret has anything to add to that as well, but we only have 4 minutes. Oh, yes, Margaret.
We only have 4 minutes. I'll just say a minute. I agree with everything that's been said. Great comments. Certainly equity and equity issues are key for World Vision as well. But I do want to just say something about the vaccine rollout, because that's going to become even more important. I think for all of us to be engaged at the right levels. So one thing that we've been doing, we participate on the COVAX group in an advisory role. And so we need to, organizations like ours need to be able to provide guidance on community engagement. I think what George was talking about, empowerment of people, and to engage on working groups where they're talking about demand side preparedness. We have an approach we call citizen voice in action, which is an evidence-based approach, and it's a social accountability model. So it equips communities to hold their governments accountable and themselves accountable. And I think it's more and more of those kinds of approaches that are going to help strengthen our work. But absolute community ownership, engagement, and empowerment is key to World Vision's work as well. I love the conversation about staffing. I agree, it's a complex discussion. As I said earlier, World Vision, 90% or more of its staff are local, but it's not, as Marian said, I won't repeat what she said, but it's not only about who does the work, and it's about so much more. So I think it's an exciting dialogue, an exciting topic that we all need to engage in, and especially as the vaccines are rolled out and we have these conversations about equity.
Thank you so much for that intervention, Margaret. It was just like the perfect capstone to end with discussing vaccines, to talk about equity, to talk about the fact that, I think COVID has been extraordinarily challenging, but with any major challenges, what's wonderful in some ways is that it also gives the opportunity for innovation, for flexibility, for space for stakeholders to start thinking, well, is this really the best way to go? How can we iterate and improve the processes that we have in place to do the most good? And I love the concept of accountability, of engagement with communities, of trust. I mean, as a health and human rights lawyer, I will say accountability is just ticks my box right there in terms of working closely with communities, whether they're community health workers, whether they're stakeholders who are just, you know, trusted by people who you're working with, as Marian pointed out. It doesn't matter about your title. It's about the fact that health is a holistic concept. And the idea of this right to health, of access to services, is not just about access to services, but it's about these social issues that have been brought up. It's about addressing stigma. It's about education. And I'm so grateful to have had the opportunity to have this exchange with Margaret, with George, with Marian today about all of the wonderful work that you've been doing and that you continue to do to strengthen health systems and to make sure that people have access to essential services throughout the world. And I wanted to thank you so much for your time today and say it's been a real pleasure to hear from you and to speak with you. And thanks so much to everyone who attended. And you'll be able to find a recording of this on our website. So please look out for more webinars from the Office of Global Health. Thanks so much and have a nice day, everyone. Thank you. Thanks, everyone.
Bye.
Thank you very much.
Thank you.
Bye.
Bye-bye.